So maybe with that, I'll go ahead and get started. I'm glad to see folks starting to join us this morning or afternoon now. I'm Bianca Frogner. I am a professor at University of Washington and director of the Center for Health Workforce Studies. But however, I'm also part of the leadership committee for the Award Network, or Advancing Workforce Analysis and Research for Dementia. And I'm really excited that we're going to have our second annual Speed Sharing Network Members Research webinar today. We're going to have hopefully 6 exciting presentations, and I'll talk about each person in just a moment. And as always, we invite you to sign up for ideas. We always welcome to hear from you about things that you want to hear about. So please go ahead and scan that QR code if you're interested in sharing those ideas. Also, you can find future webinars listed on our website, as well as through that QR code. Upcoming, we will be having another webinar on nursing home staffing policies, where we're going to have colleagues from the APT Associates as well as Moving Forward Coalition come together. This should be a really interesting and timely discussion about some politics and recent reports around nursing home staffing policies. So look out for some details in your email inbox or on the website. As always, I want to thank our webinar committee members who have worked hard to organize the series of webinars that we have. We have actually recently added a few new members, and so I'm really excited for that. We've added Jin Jun, Megan Gately, Shirin Villani as new members to the committee. I want to remind folks, you might have seen an email go out this morning that there is the Research Fellowship Program that has an extended deadline through the end of March. The RFA details are now posted to the website, so please go ahead and look for those details there. But encourage folks to apply for this. You can get $2,500 to $5,000 in direct cost to support your research. And save the date, July 2nd, we're going to have our second Award Network annual meeting in Baltimore, Maryland, that is going to follow the completion of Academy Health's annual research meeting. So we hope to see some of you there. I think it'll be a fun time to all get together and see each other in person. And just a couple other things I just want to remind folks about that I mentioned the last time. There's this ACLS Leading Edge Fellowship with a deadline of March 13th that's coming up, so take a look at that. And also, one of our webinar committee members, Emily Franzosa, is directing the Advanced Fellowship in Geriatrics at the Bronx VA, and she is leading this program that's a 2-year post-residency, postdoctoral, and postmaster's fellowship program for physicians, dentists, and associated professions and PhDs located at the Bronx VA. So take a look at this. It's an exciting fellowship, and they're recruiting today. As always, I also want to acknowledge our wonderful leadership committee of the Award Network, some of who are here today. So thank you so much for everyone's great work, especially Joanne Spetz, the PI of the Award Network, and of course to our funders, NIA. So with that, we're going to go through our series of speakers. We're going to start off with Brittany Pond, followed by Alfred Bioche, and then we're going to have Jin Jun, Elham Mahmoudi, hopefully. I don't know if she's on yet, Kathleen Kennedy, and Karen Eggleston. So with that, I'm going to go ahead and have each speaker pull up their slides, and they're one by one, and I'm going to keep time here. They're going to have about 8 minutes to speak. Oh, and there's Elham. Good to see you over there. Thanks for joining us. So I'm going to keep time, 8 minutes each, give them about a minute warning. We're going to have about a 1-minute transition period / time to answer any quick questions. I do encourage people to use the chat function to post any questions and for conversation to continue there between presentations. So with that, I'll go ahead and ask Brittany to pull up her slides.
Hello. Hi, everyone. I am just clicking the share screen button. Here we go. Everyone see that okay?
Oh, looks great.
Okay, awesome. Thanks. My name is Brittany Pond. I'm a PhD candidate at the University of California, San Francisco, and today I'll be presenting part of my dissertation work titled Institutional Disenfranchised Grief, Direct Care Workers' Qualitative Experiences. Let's see. There we go. There are over 4.7 million direct care workers who provide care and services to older adults and people living with disabilities in the United States. The older adult population is growing, as is the demand for home and community-based services. This workforce is disproportionately comprised of women of color who face challenges such as low pay rates and minimal benefits. Despite their critical role in our long-term care system, direct care workers receive little support or resources regarding experiences of client death and navigating grief. Despite the known consequences of complicated grief and the lack of administrative support, little qualitative research with direct care workers details processes of grief and loss. So today, I will discuss how direct care workers and their clients form close family-like relationships, which makes them vulnerable to grief, and specifically to disenfranchised grief because of the social construction of their relationship with clients that doesn't see this grief as legitimate. And further erasure or delegitimization of their experiences by a lack of agency or institutional support. Before I continue, I want to specify my use of the term direct care worker throughout this presentation. According to the U.S. Bureau of Labor Statistics, there are three main occupational categories that comprise the direct care workforce: home health aides, personal care aides, and nursing assistants, sometimes referred to as CNAs. I also interviewed folks who were home care aides or identified as home care workers as well. Specifically, this work focuses on paid direct care workers who primarily provide services to non-family older adults in the U.S. context. I recruited participants by contacting home care or home health agencies via phone or email to distribute a flyer. I conducted semi-structured interviews on the phone with 43 direct care workers after screening for eligibility. And in this table, you can see participant pseudonyms, their gender identity, racial identity, the number of years spent caregiving, and their average number of clients per week, which does change sometimes, but this is just their average. This table only reflects information for participants whose excerpts appear in this presentation, and in the overall sample, the majority of participants identified as women of color, which is consistent with the literature, and these participants in particular had between 2 and 3 clients per week. Today, I'll be discussing two main themes: family-like loss and disenfranchised grief, which is split into a lack of social support and a lack of institutional support. Direct care workers that I spoke with formed close bonds with their clients and discussed feeling like family, again, despite primarily providing care and services to non-family members. One participant, Jonathan, shared his close relationship with his client and said, "He's like my dad. I call him Pops and he calls me son." The majority of direct care workers noted that the death of their client was the most difficult aspect of their work. For example, Olivia here said, "I've had a few that transitioned. They end up on hospice care and I've become so close to, I've always been close. It's like taking care of family members to me. And when they die, that's hard for me. That's the hardest part of my job. You know, I miss them." Here, Olivia expressed the deaths of her clients were difficult and was akin to losing a family member. Another aspect of this work is exploring interactions with direct care workers and their employers at home health or home care agencies. Here, Isabel noted establishing family-like relationships with clients and also explained how the home health agency discouraged that relationship. She said, "I've always been very, very close. You need to treat them like it's your family." They might say, "Don't get close to your clients," but that doesn't make any sense. You're taking care of somebody. How are you not supposed to get close? The agencies say, "Don't get close to your clients because if they die, you're gonna..." Well, everybody dies. Isabel's experiences highlight the family-like bonds established between direct care workers and their clients, and further explains how institutions often discourage this closeness because of difficulties in navigating loss when clients die. Rather than these institutions offering support mechanisms for encountering grief to their employees, they often discourage close relationships with clients instead. Other participants internalized these messages and said things like, they, quote, "couldn't help but to form a bond," implying that they shouldn't form that bond. Again, perhaps suggesting an internalization of this kind of institutional discourse about not forming those relationships. Despite these close family-like bonds, direct care workers often didn't receive social support similar to family members when experiencing a death. Here, Jenny said, "I think it was a little harder because it was during the holidays. I was sad when she didn't get to spend it with her family and such, but I got distracted also within the holidays. My family was there for me, even though they didn't really know what was going on. Having people there for me, but not necessarily with them knowing." In this excerpt, Jenny noted how her family didn't really know what was happening, that she was struggling with the loss of her client. When a family member passes away, the death is usually known, discussed or processed together as a family or even together as a community. But here, however, despite feeling these family-like bonds and a family-like loss, Jenny's family wasn't able to identify or help her in her struggle navigating grief. Institutional or agency support varied greatly in the folks I spoke with, from participants reporting that counseling services were offered, unsure if any services were offered, or noting that services were not offered at all. Although there was a big range of support, the majority of participants who experienced the death of their clients said that they were unsure or unaware of any institutional support mechanisms. When asked whether their agency offered support, Kathleen shared, "I'm not sure about the agency. I usually go to the viewing at other companies and then see, because sometimes the family wants them private depending on the situation." Here, Kathleen was unsure about support or resources offered at her current agency. She explained how she often attended a viewing, or also known as a wake, at other companies when her clients passed away. And again, this is reflective of the majority of participants, that they were unsure or unaware of what institutional support mechanisms they had access to, which often resulted in contemplating quitting or moving in and out of this workforce. So here, Pauline explained how she shifted in and out of the direct care workforce because of burnout related to loss. When asked, what advice would you give to someone newly entering this field, Pauline said, "This can be a burnout job. It can be, mainly because of loss. The end result is we're going to lose them, but we're fortunate to be in their lives when we are, because this is when they need us most." And there's been times throughout my career, I've been working for over 30 years now, that I've stepped out of the healthcare field. I've gone into something totally opposite because of the burnout. But then I find myself being pulled back in again. Here, Pauline discussed her feelings of knowing that clients would eventually die, experiencing burnout, and how this moving in and out of the direct care workforce impacted her. Some participants saw bigger career changes overall due to their struggles with the deaths of their clients. Finally, this work demonstrates that direct care workers experience disenfranchised grief both socially and institutionally, and has implications for policy implementation and practices to better support this workforce when navigating grief. Some examples include paid bereavement leave, or peer support groups, or mental health coverage under insurance. Lastly, I'd like to thank all my participants for their time, my dissertation committee, and funding provided by the UCSF Patrick Fox Research Scholarship. And lastly, thank you all for listening.
Fantastic, and right on time there, Brittany. Virtual applause to you. So in the meantime, we'll have her pull down slides and have Alfred go ahead and pull up his. And this transition, are there any questions? You feel free to, again, post them in chat or continue the conversation along the way, also in chat. And feel free to raise your hand or unmute yourself if you do have any questions. But otherwise, Brittany, I thought that was really fascinating to hear that perspective and about the role of grief in the job of being a direct care worker. That just isn't often talked about. Okay, so Alfred, I'm sorry, I think I might have mispronounced your name earlier, but it's Alfred Boache, correct? Okay,
That's
fantastic.
cool.
Great to have you here this morning. So why don't you go ahead and get started?
Okay, hi, everyone. Thank you so much for this great opportunity to always share my work to people. And I want to thank the leadership for this opportunity, and also Brittany for giving us that great background information in terms of the direct care workforce demographics. And I just want to add up that even though we are hoping that there will be an increase in the number of direct care workers over time, we are also to expect that more direct care workers will leave the workforce. Why am I saying this? Because there are several issues that need to be addressed, and I have been following the PHI report on direct care workers, or the direct care workforce, and I always see issues about pay, I see issues about trauma, I see all those things that these direct care workers go through. And so in this research, I wanted to identify what kind of traumas they experience and how we can help empower them. We can make them more resilient by developing some coping strategies that they can use in their line of work. And so that is the aim of this research, is to examine their experiences and how it affects their ability to provide care, and then also identify some empowerment practices that they themselves, as well as their organization or their employers, can adopt to help these direct care workers to support other adults or residents in nursing homes or long-term care, as well as people living with dementia. And also, I want to say that I interviewed CNAs, and so my primary target was CNAs, and I'll talk more about that when I get to the methods section. Yes, so I use purposive sampling, and I interviewed 25 direct care workers in 2 nonprofit nursing centers, and I want to say that my population was more diverse because I had someone who was white, Caucasian, yes, and then I had an immigrant, I had Black Americans, and predominantly women, yes, in my sample. And the average time period for working within these nursing homes were between 1 to 10 years. And most of them were making, or the average wage was around $30,000 a year. And they had multiple traumas that they had experienced either at work or at home. And unfortunately, COVID came to add another layer of this trauma to these direct care workers. And so out of the research, these were some of the themes that I identified, that there were COVID-19 uncertainties, there was anxiety, there was panic, stress, and this led to collective trauma. And one of my participants actually said, when COVID initially started, they wanted people to reuse masks and stuff like that. No, I went on Amazon and I bought me the mask, bought my face shields and all that cost. No, I'm not going to reuse it. And these were real situations that were happening within the nursing homes where these direct care workers felt that they were not protected and they were not supported enough. And the other was the strained communication and relationship between these direct care workers and the residents, because they had actually lived with these residents for long, and they go to work. One actually recounted how she went to work, smiled with a resident. The next day she got back and they said this resident died of COVID. And it was very traumatic to them. Others also was the fact that there was a staff shortage and of work overload. And so during the COVID period, you will realize that we had people actually leaving. Those that I interviewed, some said that once COVID, they knew about COVID within the nursing home, they left and they had to go and look for jobs elsewhere. Some even came to interview and they asked them, do you have COVID here? Or have you reported any COVID case? They said yes. And she said, well, I don't want to continue the interview. I don't want the job again. And so people were scared, and then it led to this work shortage or workforce shortage within these nursing homes. And there were personal traumas. Some had genuine personal traumas that they had experienced. So this direct care worker said, a bad breakup, bills, and then I had COVID. I couldn't go out of my room, and that was very, very depressing. The breakup part, I just had to pray myself out and didn't think that I never wanted nobody else to take control of my life like that. And in the end, they talk about how she had to go back to work even after this bad breakup. If she doesn't go to work, who is going to take care of those residents? Who is going to help support these residents or people within the nursing homes who are living with dementia? And so out of this, I want to make a few propositions, and I want to tap on the definition of trauma-informed approaches in helping to resolve these kind of traumas and making direct care workers more resilient by using the Substance Abuse and Mental Health Services Administration's definition of trauma-informed, where they talk about the organization being able to identify these traumas and trying to understand and incorporating it in their policies so that they become more trauma-informed. And to be trauma-informed is about safety, choice, collaboration, trustworthiness, and empowerment. We need to make people feel safe, as well as have choices to make in terms of scheduling. If they cannot make it to work, they should have that flexibility to reschedule their work and still come back not being fired. And then there should be collaboration between direct care workers and their employers. And there should be trust. Everything is built on trust. If they don't trust their employers and their employers don't trust them, then how are they going to be empowered to work, as well as empowering them, giving them that opportunity. And one strategy that they identified was something that we call Code Lavender, where a direct care worker is not able to work, and they quickly tell a friend who is termed as a buddy to say that, well, can you help me on this? And then they switch, and then the person can go. And most of them used faith and religion because they felt that that was the best approach to solve some of these issues. And in the end, I want to summarize and say that direct care workforce is very essential when it comes to our residents, when it comes to long-term care and long-term care services and support. And so if they are traumatized, it affects the kind of work that they do and the support. And so we need to come all out to provide measures and empowerment practices to support these direct care workers. I want to thank all my direct care workers who were ever ready to come out to share those great experiences and how we could help navigate this challenge together. Thank you.
Wonderful. Thank you so much, Alfred. And again, great to see people on time and keeping things moving, but yet packing in so much important information. So virtual applause to you, Alfred. And if there are any questions, please, again, feel free to add them in chat or raise your hand. And we have just a quick moment here as we transition to Jen as our next speaker. So I'll have Jen go ahead and put those up. And I'll just say what a nice complement of topics there has been so far with this focus on the direct care workforce and kind of hearing their voices. So I'm not seeing any other questions, but for now, let's go ahead and move forward with Jen. And if we have time at the end, we'll come back and allow for some extra time for questions. So Jen, please go ahead.
Yeah, I just want to make sure that I have the right slide up.
Yes, it looks
okay,
right.
Perfect.
Yes.
Sometimes I get very confused. Well, thank you so much for this opportunity to present my work about direct care workers and preventive care utilization. My name is Jin Jun, and I am an assistant professor at the College of Nursing, Ohio State University. So today, I don't think I need to spend any time talking about who direct care workers are. I want to start with a brief summary of the health disparities in relation to occupation and wages. So when somebody has a occupation that has a low wage, so low wage earning occupations, the persistent low wage work across lifespan is associated with increased mortality. It's also related to or associated with faster cognitive decline, also with obesity. So these are all low wage work jobs. So what about direct care workers? So our direct care workers, sometimes called healthcare support workers, include nursing assistants, home health aides, and such. They actually have increased prevalence of hypertension and cardiac disease. Not surprisingly, higher rates of injuries, and these are occupational injuries, and also sadly, higher rates of depression and suicide. So this actually got us really thinking about this health disparities. We know that they have a higher risk for physical injuries and stress, as other presenters have nicely showed. But I think my team and I, we thought that there's something else beyond that, because when you have a job employed, theoretically, there is access to healthcare, especially when they're in the setting. So it got us really think about what about people do for living determine their health. So we actually use the National Health Interview Survey. We use the 5-year data from 2014 to 2018 appended, and we examined their the health behaviors, mental health status, and preventive healthcare usage by occupational groups. So we actually grouped also in the NHIS data set, you have access to occupational code. So we use the publicly available data set and categorize people into health support workers, higher wage group, which is clinicians, and the general population. So this is a bivariate analysis. And there were some group differences. So we ran a logistical regression. So I'm going to show you that. So when we compare the low wage workers in healthcare, so the healthcare support workers, to clinicians and also to general public, what we found was that healthcare support workers had higher rates of anxiety compared to either group. However, compared to the clinicians, the healthcare support workers were 50% less likely to use preventive care services and also receive less flu vaccine. However, there was the opposite compared to the general public, which kind of got us thinking that maybe, there's something else that's going on. That this led us to a second study. We wanted to collect our own data to confirm and see what else is going on, because this is a secondary data analysis and some variables were not available to us. So we used the American Population Panel, which is a repository of research participant volunteers that is available for any researchers actually, and it's available here at The Ohio State University. And there's more than 55,000 volunteers in this panel. So we screened the people in the panel and selected only those working in healthcare settings. So this was a descriptive study. And we just finished the analysis, so I'm going to show you the results of that. For the results, I want to just show you how we categorize the workers in this sample. We used a similar approach, so the clinicians, the higher wage workers, and the healthcare support workers, but in this particular study, we also included healthcare service workers. So when we compare the presence of health insurance and the benefits, we actually found that, good news, more than 91% of the healthcare workers had health insurance through their work. The vision and the dental coverage were a different story, but what was really interesting was this difference in the benefits, the flexible spending account and the paid time off. And the one all the way to the left, the darker color, is the service workers, and the lighter color is the clinicians. We also looked at the preventive healthcare utilization. So these are the 13 preventive care screening that's recommended by the U.S. Task Force. And there were different group differences, and not all screening was bad for the lower wage workers. What was really interesting was the chronic disease, as my first slide shows that our direct care workers has a higher rates of hypertension and chronic disease, or the cardiac disease rather. We actually saw that the screening for those things were a lot less in the lower wage group among these workers. We also asked the participants, what are the important drivers for them to seek preventive care? And these were comments, and we pulled out keywords from their comments and categorized them into intrinsic versus extrinsic driver. And the intrinsic driver, or the internal factors, were, I don't think any of this is surprising. The external driver, the most commonly mentioned one, was actually healthcare experiences. This was very interesting to us, and affordability and accessibility were also mentioned. So what does this all mean for me as going forward in development of my program of research? And what does this mean, for us, people who care about this particular population, and to the public? And last slide. So we are adding to the existing evidence that there are differential utilization that's going on by occupational group, and the needs are more than just healthcare insurance. And I think this is all not too surprising. And last thing is that we need a different approach to really understand what's going on in the health disparities among this particular occupation. So these are some of the references, and thank you so much.
Thank you, Jen. You actually still had another minute to go.
I'm so worried about the time.
No, fantastic. I know you packed in a lot of information there. And again, if there are any questions, feel free to post it on in chat, or raise your hand here as we just take a moment. We're going to transition over to Elham. So in the meantime, I can certainly have her bring up slides. But I love this ongoing theme about the direct care workforce, and it's kind of been a nice complement of work being presented here, hearing from the experiences of the direct care workers to what are some of the solutions that are kind of elude really direct care workers in terms of not having access to paid sick leave, which is so critical for them to address the challenges that they're facing on their work.
All
Great.
right.
So Elham, yeah.
Yeah, give me 1 second, because the format is different.
No.
I did not. We started doing this in our lab, not providing any slides. So tell me at the end how this. Okay, let me start. Let me just set my timer. Hi everyone, I'm Alham Mahmoudi. I'm an associate professor of health economics at University of Michigan. And today's talk is about differences in spending among people with and without dementia, comparing traditional Medicare or Medicare fee-for-service and Medicare Advantage plan. So the motivation for this study comes from the fact that healthcare spending, especially among older adults, it's rising rapidly. Just to give you some statistics, in 23 last year, the US healthcare cost for about 6.7 million people with dementia, and it's an umbrella term, people with Alzheimer's disease and related dementias, was about $345 billion. And this number, this estimate, by 2050 is expected to rise to $1.1 trillion, which can bring basically Medicare to its knees and basically put the solvency of Medicare in danger. So the rising healthcare cost is looming. The reason that I'm interested between the differences between traditional Medicare and Medicare Advantage, for those of you who don't know or not familiar with these options among Medicare enrollees, Medicare fee-for-service is a default plan. As it says, it's fee-for-service. You go to see a doctor, you pay for the services. There is no network or limitations. And it's federal, so they can go to any hospitals or provider that accepts Medicare and get the service that they need. Medicare Advantage, it's a combination of a lot of services, is federally administered and run by private sector. They're managed care organizations, so they do have incentives to put an emphasis on preventative care and lower use of resource-intensive services, such as hospitalizations, for example. So our hypothesis was both among patients with dementia or non-dementia patients, the healthcare use and cost should be lower in MA versus TM, and I'm using the abbreviation for both. So for this analysis, we used medical expenditure panel survey. For those of you who are not familiar with the data, it's again similar to the prior talk. It's publicly available. It's nationally representative, run and administered by ARC-HRQ. For this specific study, we used 2011 to 2020 data. We limit our analysis to community dwelling older adults 65 and older with and without dementia diagnosis. We get the diagnosis through medical record files using ICD-9 and 10 codes. We had about 54,000 people, participants, and about 2,400 of them were diagnosed with dementia. And proportion of MA versus TM was about 40% versus 60%. This is a cross-sectional retrospective case control study. We used multivariable generalized linear models and used the appropriate distribution. We used gamma distribution for cost, healthcare spending, and negative binomial to count the use of services in healthcare system. And in MAPS, we have various specific divisions of healthcare use and spending: inpatient, emergency room visits, outpatient, office, home health, and prescription drugs. We applied two-part models because there are lots of non-users of specific services, for instance, hospitalization and emergency room visits. And we adjusted all our models for age, gender, race, ethnicity. It's a very rich data set if you're not familiar with it, for both socioeconomic and demographic variables, family income as a share of the federal poverty level, Medicaid enrollment, educational attainment, comorbid conditions, which was based on self-reported data, and perceived physical and mental health. We also use inverse propensity score matching because there's a huge body of literature on differences between those who enrolled in MA versus TM. However, in recent years, that notion is kind of fading. It used to be that MA, because it was from the private sector, they had a tendency of enrolling much healthier enrollees, and we wanted to be able to basically compare our cases and control and reduce the selection bias by using this method. Though we didn't see much of an evidence for it in our data. So our results, to start with, the first one is not surprising. Between people with dementia and non-dementia, again, not surprising, both adjusted predicted total and out-of-pocket costs for dementia patients were substantially higher than patients without dementia. Just to be specific, it was about $5,500 more for total and about $1,000 more for out-of-pocket. Again, not surprising. For patients with dementia, the emphasis was among dementia patients. White patients with dementia, compared with their Black and Hispanic counterparts, had the highest total and out-of-pocket spending. And that was substantial, for instance, especially in comparison of between Black and white enrollees. For example, white patients spend about $5,000 more in total healthcare compared with their Black counterparts, and $2,500 more in out-of-pocket costs. In total, again, among dementia patients, Hispanic had the lowest likelihood of any hospitalization and emergency visits compared with both white and Hispanic, white and Black people. And again, that matches with the literature in general. And what was significant to me and interesting was white patient, again with dementia, had the highest number of office use and spending for office visits compared with Black and Hispanics. Again, to be specific, white compared with Black patients with dementia, white people had about, this is adjusted predicted difference, more about 6.4 more visits, which is about 1,800 more spending just for office visits, and had 10 more prescription refills than their Black counterparts with dementia. And the same for in comparison with Hispanic patients, which I'm not going to go through. But the main finding that was contrary to our hypothesis was about the difference between traditional Medicare and Medicare Advantage. Contrary to our hypothesis, we did not find any significant difference between traditional Medicare and Medicare Advantage, not just among non-dementia patients, but also not among our dementia patients, which is surprising and contrary. I used Medicare claims data, and I consider that as a gold standard for this type of analysis. And we had access to Optum data, which is about 25% of Medicare Advantage claims data. Again, as a gold standards, our findings were different from what we found from claims data. We also did not find any advantage over use of MA over traditional Medicare with respect to racial ethnic disparities, meaning that racial ethnic disparities exist both in MA versus TM, but MA enrollment, because they have more minority joining Medicare Advantage, did not reduce the disparity compared with traditional Medicare. Again, that was contrary with our prior findings. So we went through, rechecked everything, redid all the analysis, and the findings are the same. I also checked other studies that have used MAPS, Medical Expenditure Panel Survey, and they came out, they didn't do exactly the same study, but they came out with almost the same results. So that's a surprise. And if you have any insight, I am you're more than welcome to share. And that's a good point, because we are in the process of writing the manuscript, so we can include your suggestions. Thank you so much.
Thank you so much. A fantastic presentation, and it really so rich, I can see, and it's hard to probably fully appreciate just how much work really was put in there just in that short presentation. But I know just how much has probably gone in there. Raises so many questions. I'd love to have like a drink with you over time just to chat more about these findings, because there's some important implications about maybe how our clinicians might be treating different types of patients that's leading to these different kinds of care patterns. So very fascinating. Yeah, Catherine, so we'll have you come up and pull up your slides, but thank you again, Elham.
Sure.
Yeah, on presenter mode. Oh.
I'm trying to get there. Let's see. Okay.
Great.
Does that look
Perfect.
good?
It looks good.
Okay, well, thank you for having me. My name is Catherine Kennedy, and I'm delighted to present a study that is currently under review with a team of co-authors at the VA. The study is really about implementing Montessori approaches after staff training and understanding how staff perceived Montessori training and their whether they're able to move what they learned into practice. The study was supported by several VA Veterans Health Administration, Office of Research and Development, Office of Academic Affiliation, and VISN-1 Career Development Award. The rationale for our study really rests with the lack of studies on how Montessori approaches impact staff. Although Montessori as a philosophy and distinct approach has been evaluated or widely studied, and it's been shown to have support in terms of enhancing resident autonomy, in providing meaningful roles and occupation, specifically for residents with dementia who reside in long-term care. As an approach, it really hinges on 12 principles that you see on the screen. These include really focusing on what the person can do, matching your speed to the person, and other approaches to offer support and enhance their autonomy as a central principle. At the VA, scientists have adapted this approach that was originally developed by Dr. Cameron Camp, who is a psychologist, and it's now Montessori is being used with older adults with dementia, and also now in the VA setting, called community living centers or nursing homes. So to date, there is not really a substantial evidence base around how Montessori training affects staff, and specifically around outcomes beyond improvements to knowledge. So our study contributes to the literature by focusing on areas including skills and confidence, and notably like the starts of behavior change and outcomes. As our unique lens.
Sorry about this, Catherine.
It's okay. I hope I did not do that.
No, I think it was just a change in host. Apologies.
It's okay. So the adapted training is quite unique and really shows best practices in dementia training. So it involves 2 training tracks tailored to the staff roles. So there was an introductory training about 80 minutes, offered asynchronously or live virtually, and also a champions training So if participants, if staff at enrolled sites wanted to do these trainings, the maximum time was 4 hours of virtual training. They were led by expert facilitators, and they included staff videos of how they could apply what they learned. We used, like I said, normalization process theory, which is helpful for implementation scientists and how science and how innovations are adopted to routine practice. We focused on coherence and cognitive participation. And coherence is how teams begin to work together and plan activities. And then cognitive participation is more involved, such as creating networks for or communities of practice. So kind of like working with other disciplines on a team. We had 4 different sources of data. We had semi-structured interviews with peer leaders, and we had also exams and evaluations after they completed training. Also optional validated surveys, which used measures to assess how the intervention was becoming normalized and part of routine practice. Our interview data supported 3 different themes that were concordant with the NPT dimensions. And our analysis approach used qualitative content analysis with 4 different team members. The first major theme related to knowledge, and participants really grasped the idea that they grasped the benefits of using Montessori compared to their prior routines. So these are some exemplar quotes. One of the chief nursing officers said that it's going to force the pace to slow down a little bit and meet people where they are. It takes a different way of talking to people. The nurse on the right-hand side said that they hoped staff can offer choice and focus on what the person can do, which is, again, a key principle of Montessori. And the center quote shows that hope for staff to coach or help somebody through something in an appropriate way rather than just doing it for them. So it shows that they're able to grasp these 12 key principles. And then the next theme or major topic was around self-efficacy or confidence, that they could start to try what they learned. So, this resident assessment coordinator said, "I do know enough to try. I'm excited where this is going to go." A social worker reflected that when I see other people doing Montessori, I feel more comfortable with it. So the major really feeling from these interviews was that the peer leaders were willing to give it a try, and they were willing, and they had very positive attitudes towards Montessori. They were able to form a connection with what they already knew in their professional practice to what Montessori was giving them. And the final theme was readiness to act. So our interviews that occurred up to 5 weeks after training, the staff reflected multiple ideas of ways in which they were already trying out their new strategies. So a nurse said, "A few of us are trying to implement as much as we can." They were creating meaningful job lists of meaningful, productive jobs that residents can do to feel like they're home. And then this quote from the registered dietitian reflects this collaboration between, dietitians and recreation therapy, in terms of, designing activities that were resident-centered, and starting staff to meet with each other and talk about what changes they could make to their programs. So they said, "We're meeting to do those kinds of things." So the staff reflected not only, internalization and starting to take action steps with their teams. But they also were using materials provided. And one of those materials is Montessori readers. And when staff used the readers, they were particularly surprised, reflected in the quote in the middle here, where just sitting with some of the guys, we took out one of the books. And I can't read the bottom piece. There you go. Because I don't think that they had recognized the capabilities of some of the guys had.
Thank you, Catherine. We're going to have you wrap up there. But this
Okay.
is so interesting to hear this innovative approach to thinking about how to support our clinicians in caring for people with dementia. So I really
You're
appreciate
welcome.
this, and I hope folks will certainly get a chance to hear more about this at maybe a future presentation. And
Yes.
I apologize for kind of that little blip in there about the recordings. But maybe with that, we have last but certainly not least, Karen, please go ahead and pull up your slides. And thank you again, Catherine.
Yes, thank you to the organizers for including our comparative work in this session. I am here on behalf of my co-authors to talk about our work on robots and labor in Japanese nursing homes. This is joint work with Young-Suk Lee at the University of Notre Dame and Toshiaki Iizuka at the University of Tokyo. We, of course, are very grateful to our funders, both in Japan and here. So in this research, we're trying to look at how efforts in Japan have focused on a way to supplement the long-term care workforce in a little bit of different way than other areas, because Japan has a certain context where they found that using various kinds of automation technologies might be one way to try to address the severe shortage of direct care workers. So we are using data to look at robot adoption and how that affects care workers, the tasks they perform in nursing homes, and productivity, specifically measuring the quality of care for the residents of the nursing homes, as well as the effect on the direct care workers. We first analyzed national data. What I'll be talking about today is our own survey that we developed that collected data in 2020 and 22. We have another wave we'll be getting to later. And again, Japan, we think is a good case study for looking at this issue in a comparative context because it is leading the world in terms of population aging. It has a comparatively low reliance on immigrant labor in this sector and has been a leader in robot adoption actually in other sectors of the economy, as particularly also though in developing it for long-term care, and has a severe shortage of direct care workers. So the share of the population over 65 is already higher than most in the world and expected to reach 40% by 2060. So certainly dramatic population aging. The overall population is declining, as is the working age population. And there's a growing demand for long-term care, but of course a limited supply of care workers. This resulted in a tight labor market for care workers. Japan, as you may or may not know, has a universal long-term care insurance system as well as universal healthcare system. So this long-term care insurance system covers everybody who are elderly and provides comprehensive support for daycare, home care, residential nursing homes. Government administered prices, and all of these providers are required to be not-for-profit. So in this study, we focus on residential nursing homes. It's important to note that the government for many years now has subsidized these homes to adopt a kind of kaigo or long-term care robots. You may wonder what that looks like. So here are some examples. Some of the robots are designed to assist the direct care staff so that they don't experience many of the things that lead to burnout and leaving their positions. One of the prominent complaints is back pain in assisting residents with transfers. There are other kinds of transfers that are not borne by the individual. The most commonly adopted robot that you might not even think of a robot as a kind of monitoring system which alerts during the night or during the day and tracks whether people have fallen out of bed or other ways. Also, sometimes well-recognized kind of communication robots. These actually are not adopted as often as we find in our data. Our original panel data sampled from half of the overall nursing homes in Japan. Our response rate was low, but relatively high for this kind of a survey. And in this study, I'm going to share with you some results just from the panel that responded to both of our 2020 and 22 surveys. Among that sample, which looks in many observable dimensions similar to overall nursing homes, we have about 70% of facilities that adopted one or more of these kinds of robots. Most common, again, are the monitoring robots, although there's some mobility and transfer robots included. I won't go through our empirical strategy, but just to let you know that we're controlling for many of the other facility level and other area level variables that might be correlated with adoption of robots. Our main finding is that, contrary to a lot of concern in other parts of the economy as well as long-term care, adoption of robot was not motivated, nor did it lead to a decrease in direct care staff. Actually, we found an increase in care workers and nurse employment, although not much change in full-time equivalent. So what was happening was that there were more care workers or equivalent to CNAs called care workers in Japan that were on work contracts and that had fewer hours rather than full-time at a given home. We also find, importantly, that adoption of robots is correlated with fewer exits or quitting from the nursing homes in the sample. So that robot adoption is associated with better retention of the direct care staff and continuing relationships with the residents in those nursing homes. This relationship is strongest for non-regular care workers and monitoring robots. We also measured certain specific tasks I can go into if anyone's curious. And we find that monitoring tasks, for example, were related to adopting monitoring robots, of course. And perhaps most interesting, we found that when a nursing home adopted robot, there was a reduction in use of restraints, which are technically illegal, but also for certain circumstances are used. There was a reduction of restraints on residents in nursing homes that adopted robot, as well as fewer pressure ulcers among their residents. There were higher occupancy rates or an increase in the wait list. For many of these nursing homes, the wait lists are quite long. So in conclusion, we find that robot adoption does not displace workers, but actually is accompanied by an increase in care workers and nurses. But these are care workers and nurses on more flexible labor contracts. And we find that monitoring robots have these largest complementary effects with care workers. We're not entirely sure of the exact reason for that, but we think this may be addressing some of the characteristics of the work that make it such a difficult job for many, because we do find that robots are associated with lower turnover and fewer care worker exits, and suggestive evidence that the long hours that they were doing were reduced. And posit, because we look at daily tasks, that as the robots assist with some of the daily tasks, that the direct care staff may be able to devote more effort or time to activities that involve human touch or motivate them to go into this sector. Overall, resident health also seems to improve. So obviously, although robot adoption is not a panacea, it might help to alleviate caregiving shortage. Thank you very much for your attention.
Thank you so much, Karen. That's so interesting to hear some of the different ways in which robots first are defined and then the different ways in which they're being used. So I appreciate that kind of overview of the different ways the work is, how robots are being incorporated into the work, and this idea of also addressing what does it mean to complement versus substitute the workforce. So very innovative thoughts there. I know we are basically out of time for today, but I do hope that these presentations inspire conversation outside of the webinar series and that folks reach out to each other, as I'm sure all of our speakers would certainly welcome continued conversation. And I hope that maybe this might even inspire some opportunities for collaboration. Oh, I do see one quick question. Just we have a quick opportunity here. Is that Catherine asks Karen, if Japan nursing homes have safety equipment as well as robots, or robots replacing safety equipment. And I see, Karen, I think you directly messaged back to me that there are many forms of safety equipment. But if you want to just make a quick comment there.
Yes, we also looked at other equipment in the nursing homes, and the ones that adopt robots also have many, many other forms of safety equipment.
Yeah, it's a great question. All right. Well, thank you to everybody for participating today, both as presenters and as listeners. And thank you for the great, everyone being on time today. So we will have this recorded and posted on the website, and please share with others. So see you next month. Take care.